What is that on your shirt exactly?
That's a barbecue rib. John, Atlanta is famous for Fat Matt's Rib Shack.
Wait, sit back a little bit. Let me just take a. No, that is a running wiener, isn't it?
That's a barbecue man.
That's barbecue man.
Yeah.
Eric, are you a barbecue guy?
I'm mostly vegetarian, so not much. Although I did live in Nashville for 4 years when I went to Vanderbilt, and
That's what made you vegetarian. All that fine food.
Well, let's put the hot sauce on this episode of Lifelines and get it started.
I'm ready for it.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
Well, welcome back to 988 Lifelines, the podcast with David and John. The water is cool. Jump in with us if you're a fanatic for innovating in the crisis space. But we're also really cognizant of the work that has yet to be done. And we explore that every week. Join us on YouTube, like and subscribe, or watch us wherever, listen to us wherever you get your daily dose of podcast. Brooklyn, we've got a great guest with us today. Please tell us a little bit about Eric.
Oh my gosh, Eric! In just 8 years, Eric, since your residency, you have a staggering number of appointments. Psychiatrist at San Diego County Hospital, a local VA, a network community treatment a network of community treatment centers. You're the chair of a work group in California 988. You're also on an advisory board for 988. You're on seemingly 3-4 other boards. You're on a congressional task force, and you just finished your residency 4 years ago. I am such a slacker. Thank you for having time out of your incredible schedule to join us today.
Well, I'm sorry you had to go through all of that, but thank you. Thank you.
Me? You're the one going through it, my friend.
Well, policy is important. This impact is important, Eric, and we're going to get into that discussion as we go today. We're coming to you from the heart of Atlanta, sponsored by Behavioral Health Link, longtime Georgia company. Hits my T-shirt today. But John, we usually get started with a little bit about our guest. Eric, maybe, I tried to find you on Facebook. And even your Instagram account's a little bit more professional. Tell us something about yourself that maybe we might not know that's more personal.
Let's see. A couple of things. So I played water polo in college, Chapman University, so Division III, NCAA athlete. So that was 4 years. Kept me also very busy.
What college were you in?
Chapman University.
Oh yeah, I know Chapman.
School in Orange County, California.
Now I understand that's a really hard-nosed sport.
It is.
Yeah, did you ever get a lot of water in your ear?
Yeah, you're in the water, you're underwater. It's a combination of swimming, sort of like basketball and wrestling all in one sport. So.
Yeah, a lot of stuff going on underneath the surface that's hard to see. So one of the things we do, Eric, to start is John and I take a guess at what you're a super fan of. Look, super fan status, right? I'm a super fan of barbecue, for an example, having grown up in Nashville. And John, what are you a super fan of?
Well, you mentioned it. I'm from Texas, and I've been eating barbecue. I grew up eating it every weekend. So yeah, I'm all about barbecue for sure.
So without a social media background and without knowing Eric better, I'm going to have to take a wild guess. But John, I've got a blank piece of paper, so I'm going to write down what I think. And Eric, your goal is to pick were John and I, which of us was closest, or neither one in the ballpark.
Okay, I can do that.
All right.
So John, I'm gonna tee off of, I know Eric's a fan of Mobile Crisis, so I'm gonna just reach from that, and I'm gonna.
All right. Okay.
Because he's a fan of Mobile Crisis, maybe he's also a fan. Okay, yep. I got mine.
All right, I got mine.
All right, so on the count of three, we're going to raise. What you got? Sleep.
Yeah, you seem like a really busy guy, Eric.
Yeah, okay, that's a good guess. I don't know that super fan makes sense, but it could. Mine is he's a super fan of Formula One.
Isn't that incredible how he just drew that?
That's just my quick effort on it. But if
And
he
you-
likes mobile crisis, John, maybe the speed of access,
I see.
maybe Formula. Eric, are either one of us in the ballpark?
Sleep would be closer. Probably Formula One would be right for my sister, who's the skydiving instructor. But sleep would.
You know how disappointing it is to David after he spent all that time drawing that and he was wrong? I mean, come on.
I was bad wrong, John. So, John, this program and interview with Eric Rafla-Yuan is sponsored by Behavioral Health Link. Tell us a little bit about the crisis platform that BHL brings to the work.
I'm happy to do that, David. Eric is doing everything he can at the state and national level to implement models for coordinating 988 crisis care. When you're trying to create an infrastructure that coordinates crisis services across counties, regions, and states, you need an air traffic control-like capability to assure care continuity so no one in crisis gets lost. The BHL platform provides the technological communications infrastructure to keep your people in crisis connected to care, starting from the call center's greeting to the mobile crisis visit to their connection to outpatient care or a bed at a crisis receiving facility. BHL's modules are designed for supporting and coordinating care for 988 call centers, GPS-enabled mobile crisis dispatch, outpatient referral and scheduling, evidence-based follow-up support, and real-time tracking to find crisis beds for more immediate care placement now. BHL's modules can be integrated independently or all together into your system to transform it into the crisis now model that it needs to be. If you want to learn a little bit more about our state-of-the-art software, just check us out at behavioralhealthlink.com. David?
Thank you so much, John. Eric is coming to us with a huge impact in the crisis space. We'll talk a little bit later in the program about first meeting Eric and him joining our Crisis Jam. But our good news for today, John, is to reflect on the Crisis Summit that we had back at the end of June in Amsterdam as part of the Global Leadership Exchange. We had 120 people from 13 countries come together, and we had debates. We had panels. John, you did a fireside chat with Monica Johnson from the 988 and Behavioral Health Crisis Coordinating Office. What were your reflections, John, on this group coming together for the third time as part of the Netherlands Global Leadership Exchange?
It's always exciting to see people who care about the same thing, coming from different cultures, talking about different ways to get to that same thing, and seeing it from their perspective. And that's what I love about visiting any culture's general, is coming back to my own culture and saying, I wonder if we could do it differently. Some things that are going to be tough to do differently. They would talk about, like, for example, the folks in the Netherlands were talking about how liability is not a concern that they have there. So they're really free to say and do everything that they can do to help an individual that they think is best without fear of making a mistake that will cost them in some way or another. They all put front and center the needs of the individual, not the fears of what would happen if they did something wrong. And I really appreciate that forward thinking, that person-centered thinking, and I wish we had more of that here.
Eric, I wonder if you're aware of some of the work Representative Tina Orwell is doing in Washington State in that very regard. She's got a bill out there that introduces some of that protection, John, from legal liability. In fact, Paul Galdus on the Recovery Innovations team was reviewing it, and his first response to me was, well, this just isn't the way we do this in the U.S. And I'm like, well, but we could if the law was changed. Eric, any reflections on the strengths and weaknesses of introducing that kind of approach into the U.S. system?
So I guess I'll back up and say, I know Tina Orwell. I've met her a couple of times. I know some of the work she's been doing. I know they ran into some issues in Washington State where there was kind of police officers and mobile crisis responders and who responds to what and who's responsible for what. And so, there was some legislation that came out of that. I don't know exactly what that looks like. So it's probably what you're referencing.
Yeah.
To the bigger picture of first response and liability, I think it is complicated. And this is one of the things I found working on 988 because it touches so many other systems.
Right.
And each one has its own liability and professional code. So law enforcement, firefighters, EMS, emergency room personnel, and they're all governed by a different set of laws and regulations. So it is complicated. I think that it was probably very refreshing to see what they can do in other countries where they don't have this huge medical liability kind of driving how care is delivered. But it would really need to be a system-wide approach to be useful, I think.
John, I think I'll show a brief video from the Amsterdam event. And Eric, would be great to have you in 2026. We hope to have the 4th gathering of this group in Washington, D.C., when Global Leadership Exchange is back on this side of the pond. Let's talk more about that. But this is a quick synopsis of the event. So the planning begins, John, for the next event in 2026.
Yeah, definitely looking forward to that too, David.
John, maybe you could start us off with our formal sort of discussion with.
Yeah, I'm happy to do that. As I was remarking earlier, Eric, you're a busy guy, but what you're doing is so meaningful for so many people, and what I'm seeing is kind of a running streak through what you've been involved in these years. Has really been a lot of advocacy with a credible work ethic and a passion for crisis services. And I'm wondering how all those come together. If there's something driving that interest and that passion that you could talk about.
Yeah, no, it's this question that I get a lot of times because people say, doctors don't normally do all of those things. Tell me about how you do it. How can I do it too? So as you noted, I think from maybe looking at LinkedIn, a lot of the stuff that I started doing, which I continue to do now, happened during the very first year of residency. And one of the things that was really a formative experience for me was working night after night in the safety net hospital's emergency room. So there's ambulances bringing in people in mental health crisis, or police officers bringing and dropping them off, basically often from downtown or the greater San Diego area. They would get dropped off night after night, and I'd be there for these 14-hour shifts night after night taking care of these folks. Sometimes the same person, multiple nights in a row, and they come in and you give them perhaps a place to sleep for the night, perhaps a sandwich, and you send them back out into the same exact situation that they were in before. And you could hand them a piece of paper that says, here's follow-up, and you could hand them a 7-day prescription for antidepressant, say, go to a walk-in clinic, and then you see them again 2 days later. And so one of the things that doctors are often told is, well, if you just see more patients faster, then that's going to be the fix. But it was really clear to me that wasn't the fix, and that really need to have a more system-level approach. And so we have a system-level approach. You need a whole bunch of skills that they don't teach you very well in medical school. And so then this is, start off my journey into advocacy and legislative work and policy. So that's how it all started.
Started on the ground, John, not unlike the work you did in mobile crisis and I did out in going into emergency departments as a clinician. Eric, you and I first met. I think it was a Monday that I saw your article featured in the national press the New England Journal of Medicine, Decoupling Crisis Response from Policing. We were so intrigued, impressed. It felt like the impact of that messaging was so important. We cold called you. I think it was literally 2 days later you were on the Crisis Jam, our learning community.
Yeah, I know those were the early days when people were still trying to figure out what were the 3 digits that was 988.
What were the 3 digits? So give us a little bit of background, if you will, on that particular article. So as you were telling about your background as working in an emergency department as a psychiatrist, you were seeing the psychiatric boarding side of this, but your article focused more upstream on the law enforcement engagement. What was the nexus or the background of that story?
Yeah, so there's actually a background to that background, which I'll just start off with a little bit as well. So in medical school and then during residency, my research area of focus was looking at how immigration policies affected health and border communities. So started off in medical school looking at borders in the Middle East, so Syria and Jordan. And then when I moved to San Diego, looking at the Mexico-California border. But I also started residency during 2016, and there was some presidential changes and agency changes, which really made it clear that a lot of these things were really harmful. And we didn't need more research telling us about how it was harmful. We needed research to try and academic work to try and show us, well, what should we do if we know that these things are harmful? And one of the things that also happened around 2018, 2019, and then especially the start of the pandemic is that a lot of the borders were just closed.
Right.
And so one of the other cultural phenomena that was happening in 2020 was the death of George Floyd and a larger awareness across the country of the way that racism shapes American life. Still work in progress, very much work in progress, but there was a window at that time where 988 was aligning with that period.
Right.
Interest in how can we respond to individuals who are in a mental health crisis with something other than police was there from multiple angles. And so I was able to bring the medical and psychiatry angle, but there was also this kind of racial justice, social equity piece as well.
Terrific. Eric, I actually lived in Amman, Jordan for a year when I was young, and it's an incredible experience. We typically at this point do a trivia over under, and John, it's a great serendipity that our over under comes to us from San Diego, where Eric was working in that emergency department, and I'll put up the picture from the.
Are you saying this is just a coincidence, David?
Well, this background has been important to me for some time because of the introduction of community-based mobile crisis teams. And this is the police chief of San Diego County at the press conference talking about the importance of these community-based mobile teams for people with a substance use, mental health, suicidal crisis. And she said, this was, I believe, in 2022 when this press conference took place. She said, last year, my police force was involved with X number of engagements of people with mental health, suicide, and substance use crises. John Draper, what was that number? And then Eric, we'll look to you for the over-under. Is John high or low for the actual number? So San Diego County, Eric, you want to give John a little context on the size of San Diego?
Yeah,
it's
give me a
one of
sense.
the largest cities.
Yeah, I'm happy to do that. So one of the great things that I've had the opportunity to do is work at state, national, federal, and local government. So San Diego County is California's second largest county with a population of about 3.3 million. And then San Diego City, which is within the largest city within the county, has a population of about 1.69 million.
Okay, so and I have a feeling Eric might know the answer to this.
And then there's actually a question back to David, because if it is the police chief, then that's the city, but if it's the sheriff, then that's the county. So
okay, so this
my guess from reading the logo, a better way that this was a county supervisor-led initiative. So
now that you mentioned that, Eric, it says in my notes the Chula Vista police chief, Roxana Kennedy.
Yeah. So Chula Vista is another city in the county.
Yeah.
All right. So I'm thinking about what I know about New York City, since I live in Brooklyn now, and we used to have somewhere in the neighborhood of between 75 to 100,000 emotionally disturbed person responses through 911 annually, and so we're talking roughly a little bit less than half the population for San Diego County there. So I'm going to say it's in the neighborhood of 40,000.
That's a strong guess, John. I like the analytics as you walk through that. Eric, is the true number higher or lower?
Did we clarify this was for Chula Vista or this was for the county?
Well, so I clarify that what she said was she said local law enforcement. So I was in the impression that she was talking about the greater county,
Okay.
but that was the context for the launch of the mobile crisis.
Sure.
The details matter.
I'm going to guess under.
It's actually over. She reported 54,000 interactions annually. So, Eric, she may have been talking for the broader county and not just Chula Vista. And she also said it was her belief that the majority of those interactions should not have been with the police, but would better be with the mobile crisis team that's now operated, I believe, by Telecare and
majority.
The majority.
That's wow.
That's what she said. Eric, your reflections on John seems to be thinking that's high. But what's your reflection on that?
So there's a piece about data collection and how these types of calls are coded and things, but I think it's really telling that the law enforcement themselves is telling us that we think that we're not the best ones to respond to this and that this can be responded to better by mobile crisis team. I think it's also important to note that the co-responder team already existed with about 50 units during this period. And so even with all of that, there were these numbers that we're getting. And so I think it shows that there really is this huge demand for mobile crisis in San Diego County.
And Eric, do you think she's talking more about, because I know LA is doing this and there's a few other models like this that say, look, it's not just mental health needs, it's social service needs that they're responding to. And so we need to have somebody also to address the social services and determinants that are affecting whatever's happening here, not a crime or a medical issue or fire. Is that right?
So this is a piece of where it depends on how they are tracking that and defining those types of calls. But often that is the case where this emotionally disturbed individual or this social or domestic disturbance. And it may be mental health driven. It may be not.
Right.
But often in those situations, armed law enforcement isn't the ideal person to respond.
Push it that another way, John. So we operate the crisis receiving facility on the west side of the city here in Phoenix, and we'll have about 6,000 admissions this year, 80% of which come from law enforcement. They drive up, they drop the person off, they drive away. They've not been to a hospital for medical clearance. My question to the team was, how many of those interactions should have been law enforcement in the first place? And it's not a pure, again, back to Eric's scrutiny of the data, it's not a pure way of thinking about it, but a proxy on how many of those times would be, did we have to call the police back?
Right.
To have them come back out because we couldn't manage the situation.
Yeah, that's a good point.
And out of, so 6,000, 80% of that, those thousands of times, I asked our chief nursing officer a couple of years ago, and he said, I've only been here for 3 years, David, but in my time, we've never called the police and said, you have to come back. Not once.
Wow.
He said once or twice a year, sometimes zero, we will file charges on someone because they have done something beyond the pale of normal behavior of a psychiatric crisis. But even then, we don't say police have to run back out here. So that's if you even take 3 years, 18,000 interactions. Again, 80% of those were with law enforcement drop-offs. We had a handful, maybe 2, 3, 4 times that we felt like this person committed a crime. 3, 4 times out of that that number of 18,000. That begs the question of why couldn't a mobile crisis team have been involved on the front end?
Yeah.
As opposed to law enforcement coming in. Now, maybe some of those cases, John, law enforcement secured an active weapon. We wouldn't have asked mobile crisis to do that. But again, we're talking our view at Recovery Innovations. I know this is a behavioral health link product that we're talking about here, John, but at RI, we believe it's 95% of those interactions should have been a mobile crisis team or other engagement, family coming directly. It's a virtue of the way we do things, as opposed to a demand for law enforcement. Eric, does that make sense to you? Have a different add-on or a different view of it?
Yeah, no, and that matches. And I think another thing too, in my discussions with elected officials and with law enforcement and law enforcement sort of like leaders, is that a lot of the things they do, they just sort of have been, it's like because no one else is doing it, and they were never set up for do this. They were never funded to do this, but that's the number that gets called, and so they respond, and they have a duty to respond, and so they respond no matter what the situation is. And over time, this has really grown so that they are sort of one-stop shop for a lot of different needs.
Right. John, I think that's a good segue into your question about California and the task force that Eric served on.
I was telling David I had some questions about the work that you're doing in California. I mean, there's a lot of things that are happening in California that are innovative, singular, and could be models for the rest of the country. And I know that you're the chair of the 988 technical. No, it's the accessibility and
There's a lot of words, so I can help.
Accessibility and equitable access working group. Is that right?
Yeah. So I didn't come up with any of these names. So I was just like appointed.
Well, but it's all about access and making sure we're equitable about it. And David and I are huge promoters of access, care a great deal about that. And I'm wondering what some of the major challenges are that you're seeing that 988 is facing in terms of accessibility to certain populations in California. And what are some of the innovative ideas that y'all have come up with that you're looking to implement or are implementing now?
Yeah. So just a little bit of background on California, because sometimes people just assume it's a couple of large cities and a very large blue state.
No.
But actually, it is not a model for the United States, and that we have 58 counties. The majority of them are actually more rural than urban. And there are actually more than half of the counties have Republican majority county leadership, and counties are the ones that run or are responsible for health and human services and law enforcement. And so in that way, when we're thinking about a statewide approach, it is not just taking care of San Francisco and LA and San Diego. It's taking care of all of these 58 counties and everyone who lives in all of these counties. California also has a really huge population just by numbers. 1 in every 8 people in the United States lives in California. And so when we think about, well, what is the scale that we need to like project and what it would look like if it was implemented nationwide, there isn't really a better model than at California, which also has a 2-chamber legislature like the federal government. And
just to note very quickly, Eric, I think 1 in 3 people in Texas are from California now too. I just wanted to know.
I can't verify the accuracy of that number, but I can listen. So then just like at the federal government, we have a number of state agencies in California. One of them, which you might imagine is quite involved in 988 and crisis services implementation, is the Office of Emergency Services. So that's where this advisory board that I sit on or have been appointed to, that's the agency that it lives in. And that was statutorily created by our state 988 bill, AB 988, which passed in 2022.
Right.
So, and then on this board, so we review, various decisions. One of the things we're looking at now is the 911 988 transfer and interoperability protocol. Obviously, something very important. Yeah. And then this advisory board has 3 working groups, and so the one that I chair, along with our state 988 director, is the equity and accessibility working.
Terrific.
With Budge Courier, right?
So Budge is the 988 lead for the agency, and he leads the advisory board. He's the staff liaison there. But the 988 directors is actually a different agency, Cal HHS, and so her name's Antu Boy, and she's also a psychiatrist.
What are some of those challenges that you all are seeing that I don't know if they're unique to California, but they're big, and any ideas on how to address them? Is it mostly I love the interoperability experiment, and it's a huge one that between 911 and 988 in California. It really could be a model for the nation. But I'm curious about the accessibility question specifically in California.
Yeah. So I'll just start off on that interoperability piece because I think we're doing something that's quite unique in that there is so Vibrant has its national network, but in California through the agency work and our contractors, there is a state network. And so this network will interface with Vibrant's network and they'll pass calls and texts back and forth as needed. But this means that a call in California, even if it's not answered by that closest California call center, will go to another California call center. And so things will stay in the system as much as possible. Also, all of the 988 call counselors at any of the centers will be able to see the same unified platform, intra-California platform. So if there's a return caller or if their call needs to get transferred. So all of that is on the same platform. And then what we're working on now, so the technology is in place that with the push of a button, that call and some of the information goes to 911 PSAP. But the protocol is not in place yet, so that part is not live, but that's what the technology.
Does that work both ways? Will that work for 911 also transferring calls over to 988?
Yes. Yes.
Well, that's some tremendous elements. And Eric, let's get you back in the crisis jam to talk a little bit about that sub-network in California. John and I, in prior podcasts, have really been strong about the need for this marriage of state and federal, which we never really saw under the prior iteration, and for good reasons. But 988 warrants a different approach, and to see California is actually pushing that way forward. That's exciting.
Yeah, and so that contract is actually all finished, and the next contract they're working on is so to be able to dispatch to mobile crisis at the push of a button, including knowing we're all on by a GPS where all of the units are, and so
love that.
This one. And the information that is gleaned during the crisis counselor can go to the mobile crisis team, so they're not going in blind or with just very little information.
Yep. So Eric, what do you have follow up, Eric? Or?
Yeah, well, I was going to get back to your original question because that was just all stuff that I threw in there because I thought
it was. I want to hear it.
Yeah. As sure you hear in every single other state that every place is different and a one size fits all approach is hard. And so there is a very big discrepancy in both the needs and the resources available to small rural counties and large, major urban counties. Right. And so one of the things as well that in California we're working with is our state 988 legislation, which is very strong. So not only, providing phone fee and the sustainable funding for all of these types of things, but it requires that three-pronged crisis continuum approach with a 5-year implementation timeline. So now the agencies are doing the hard work of figuring out, okay, well, what exactly do counties need to do to meet that legislative requirement? With the knowledge that in some places it wouldn't make a lot of sense because of the geographic and population distribution of the county to have just one single crisis center in one corner or one middle because they don't even have a hospital, and so how would they have this? And so these types of challenges are real, and so figuring out how can we get people the services that are the most useful to them in a timely fashion that meet the financial constraints of the counties. And a piece of that is having the state support and oversight, because otherwise it wouldn't be happening at all. And so then now this pressure to make, to move this along and figure out what that product is going to look like. But I anticipate continued advocacy to ensure that the idea that there's someone to contact, someone to come, and somewhere to go which is a major part of the legislation, is true in all of the counties.
Terrific, Eric. Eric, we know you from your decoupling policing, from your work with the Congressman Cardenas and the task force. We know you because of your enormous influence on us and the learning community around the history of the development of the EMS system. But as I was looking through and desperately trying to find out what you might be a super fan of, I did come across a poem that you published in a journal. That's a first for me, but I'm sitting here reading I Can't Breathe, which is really phenomenal. Tell us a little bit about I Can't Breathe.
Yeah, so this is a very kind of surreal, poignant moment in my life. And this was in 2020 after the death of George Floyd, and there were a number of protests around the country, often in sort of like major cities, around city halls. And so I lived very close, like literally across the street from the county administration buildings, basically like a big kind of town hall building in San Diego. And so these protests were and the disproportionate law enforcement response with tear gas and things like this was like right in front of my window. So that was the context in which all of these emotions and thoughts that I was having, the poem. And then the other thing that I was having at the same time was a patient that I was working with who I would see on a regular basis, who was having panic attacks and couldn't breathe. And one of the things that I had to tell her at our last visit is, UCSD, University of California, San Diego, no longer accepts Medi-Cal, and we can't see you anymore, and I don't know where you're going to go next. And while when we went into that kind of our final appointment, she's telling me how she's having panic attacks and can't breathe, and that's sort of what I have to tell her. And so all of this was happening at the same time, and so that I Can't Breathe combined what was happening nationally, as well as kind of like the tear gas and things like that right there in my front door, as well as what I was seeing in the patients I was working with.
Do you
my emotional response to that.
Do you remember any of it offhand, Eric, that you could recite?
Of the poem?
Yeah.
I remember the people and the places. I don't know that this was
Let me read just a small section of it, if that's okay with you.
Yeah.
I'm drowning, my patient tells me, how her panic attacks are getting worse, how she sits in the shower 10 times a day, how she's so scared. She throws up when she eats. I try to think of how to tell her. The department no longer takes public insurance, while she is telling me how the walls close in on her, how she can't breathe. And I wonder if she sees that neither can I. Really poignant. I dropped it into ChatGPT yesterday, Eric. I didn't give it any context, didn't tell it was, what academic psychiatry journal it was from or who the author was, but it says this passage is a powerful blending of personal narrative, social commentary, and emotional depth. Key themes: isolation and vulnerability, social unrest and police response, health impacts and fear, institutional indifference, mental health crisis, and shared struggles and empathy. So it's a lot, Eric.
Yeah.
Hey, he's not just busy, John. He's also super talented and has this emotional core, Eric, that is so vital to this work. And so appreciate you leading this. John, what does this poem evoke for you?
I mean, as you know, we're big fans of this notion of lived expertise, where how do we apply our life experience in ways that can help others? And it sounds like you do that very poignantly in this poem as a provider and as a human being that says, I'm not just providing, I'm a person that cares, and I care for you, but I can't, you're not letting me care for you. And I think that is, or not, they're not, but the system is not letting me care for you.
Torn in the middle,
yeah,
John.
So you're just kind of, speaking to the system. We're trapped here. You're doing this to us. And I think that is a powerful statement, which not enough practitioners are saying, that they are often trapped with, no, I'm sorry, we can't cover that. Or no, I'm sorry, we don't have the tools or resources for that, or we don't have time for you.
Mm-hmm. Yeah, no, it's a lot. And this was my last year, second half of my last year of residency as well. So it was another layer was that I was still technically a trainee. So once you're like a faculty or full employee, but still as a trainee, almost part student, you have even less ability to affect system change there.
So, Eric, this transitions us into our first interactive segment, and it's a trivia around poetry, some powerful poems. And I'll first look to the two of you. John, you don't know these either. Do either of you know the author? If you don't, I'll give you a choice, and let's see if one of you might know. So our first poem excerpt: you may shoot me with your words. You may cut me with your eyes. You may kill me with your hatefulness, but still, like air, I'll rise. Either one of you know who that's from?
I don't.
It's either Maya Angelou or Amanda Gorman.
Oh, that's Amanda Gorman.
That is Maya Angelou from Still I Rise, John. I rise.
I knew it was one of the two.
But still, like air, I'll rise. Here's another one. I am the master of my fate. I am captain of my soul. Either one of you know who or what that's from?
No.
Give us a choice.
Invictus. Invictus. It's William Ernest Henley. How about this one? Do not go gentle into that good night. Dylan Thomas or T.S. Eliot? Either one of you know those.
Dylan Thomas.
That is a Dylan Thomas one. Because I could not stop for death, he kindly stopped for me. Emily Dickinson or Sylvia Plath?
I've heard the poem, but I don't know who wrote it.
Yeah, that's Emily Dickinson.
Yeah.
John, here's another Maya Angelou or Amanda Gorman. Let's see if either one of you know this one. For there is always light, if only we're brave enough to see it, if only we're brave enough to be it.
Oh, I'm going to give that to Amanda Gorman.
That was in Amanda Gorman's speech at the Biden inauguration.
Yeah.
Here's one. Started from the bottom, now we're here. Is that Drake or Kendrick Lamar?
I don't know. It's sort of embarrassing, but yeah, I don't know.
Well, I would have no idea.
Not the song.
It's a great line, though.
When I hear something with that kind of depth, this is a bias, but I would say it's Kendrick Lamar. This one's Drake. But just to be fair,
that's interesting. I would have.
To be fair to Kendrick Lamar, here's a Kendrick Lamar. I got loyalty, got royalty inside my DNA. One more. Let's see. I celebrate myself and sing myself. Is that Robert Frost or Walt Whitman? I celebrate myself.
Walt Whitman?
That is Walt Whitman from Songs of Myself. So was really inspired by your and what made you then take that poem and submit it to academic psychiatry, Eric?
I wanted it to go somewhere. I didn't want to just write it and put it in a box. And I thought that it was worth reading, like worth people reading, and maybe could get some kind of message out there. And so to get it published, and then thinking about where it was relevant and what journals, some journals, including pretty big journals, accept poems. So academic psychiatry is the main basically what it says, academic psychiatry. So research and education.
Terrific. So we talked about Congressman Cardenas earlier, and John was referencing your LinkedIn, and among your work is the working with, directing the Congressional Task Force in this regard. Tell us about that experience, Eric, and what recommendations you're driving, and what success you've had, what challenges.
Yeah, so that was an amazing window of time, and someday I'll people said you should write a book about what 988 on the Hill during that 2021, 2022 period was. So the 988 enacting legislation, basically it said 988 will go live by FCC on July 16, 2022. That had passed. That was done. And as far as people on the Hill thought at the time, okay, well, we're done with it. We already did it. But there was no funding. There was no other federal work on this. And it seemed like it was going to be a disaster, or at least not live up to the potential that I thought it should have and could have, and others like at SAMHSA, and you all saw with the full crisis continuum of care and 988 being a robust entryway to that. And so one of the first things I had to do was just educate people why this is important and why we should do something else about this. And so Mr. Cardenas, Tony Cardenas, Los Angeles Democrat in the House, he was an amazing Congress member to work for, and I really admire him and the work he's doing. And he's actually retiring at the end of this year, which is a travesty for California and for the country. But he had actually for a number of years done a lot of legislative work and oversight on how can we have other folks do jobs, not just law enforcement. Or how can we make sure that people that are doing this have the right training? So like an idea he had is, well, when people go to police academy that gets paid for. But when you go to social work school, that you don't, you have to take out loans. And so why is there that discrepancy? And so he had sort of been thinking about these types of things, but not exactly with the mental health focus. So he is a psychiatrist working in his office. When I brought this all together, it made sense to him, and he was quite supportive. And so we got his support, and then we had to go around and because you need more than just one member of Congress to do something. And so went around educating more and more folks about why this was important. And it's also, federally important to be bipartisan in order for things to pass, and also bicameral, so both through the House and the Senate. And so a piece of this is building a legislation that has a lot of supporters from many different walks of life. So it's not just like the mental health bill with all the regular mental health supporters that are signed on, but something that the National Association of Counties is signed on to, then National Education Association is signed on to, and law enforcement groups are signed on to, and civil rights groups are signed on to, like a lot of groups that generally don't sign on to all the same things. And so then this got attention and it got news presence, and so it built momentum through that. And so we were able to do a lot of things. And then eventually this all got what happens often with federal legislation is get rolled into larger packages. And so a lot of different bills got rolled into a bill that passed the House, HR 7666. And then a lot of that was taken and put into the omnibus package, the Consolidated Appropriations Act, at the very end of 2022. But we authorized and we created and funded the 988 Coordinating Office at SAMHSA.
Right.
And a piece of that was I had to educate folks, why this was important and why this needed to be its own office. And there was a proposal, actually, a counter proposal that came back to us from the committees that said, well, you should just put this in like the innovations lab at SAMHSA or something like that. And so we had to go back and forth through all of these little things that no one out there knows now, but me and a small number of people know. But the world is how it is today because of this work that we did, and that's something we carry around all the time. But I have a number of nuggets like this, which maybe one day will be done.
Eric's responsible for the 988 office, David.
Well, but Eric was also, and we'll get to this in the next trivia section, Eric was also influenced by the development of the emergency medical system, which is an amazing national infrastructure. And the tools that built that, I see you constantly going to that as you're thinking through. That's tremendous. John, you have another area of interest.
This is right along the lines of you're always, again, you're a relatively young guy, and you are in these very influential positions where you can advise and advocate from a very important perspective, as you did here with Congress. And you're also the vice president of the Association of LGBTQ plus psychiatrists. And obviously the political climate these days presents all sorts of challenges for transgender affirming interventions and proposed homophobic legislative initiatives. So from the psychiatric perspective, Eric, what are some of the primary messages that your association is sharing with the field And how receptive has the field of psychiatry been to these recommendations?
Okay, so I have like a lot of different hats, so it's like picking off the congressional hat, picking off the HELP hat. So the HELP is actually has quite an interesting history. It's the oldest LGBT professional organization in the United States.
Wow.
And responsible for that. Its forming was the members that formed it were responsible for the advocacy to remove homosexuality from the DSM.
From the DSM, absolutely. Yeah.
So it has this important history, and it's
right.
moving along. One of the things that has happened over time is that sort of the main psychiatric association, American Psychiatric Association, now a number of its position statements and things like this are things that we've worked with them on or that mirror what our positions are. And so I would say actually from the professional association side, and not just psychiatry, but broader American Association of Pediatrics, American Medical Association. So all of these major medical associations have been very kind of up to date on what the evidence is and having up to date policies that reflect that. Part of the challenge is, though, that then is what state legislatures and sometimes Congress doing. Does that reflect what evidence is, or does that being driven by something else other than evidence? And so one of the things that I'm personally interested in is coalition building and also thinking about what do we need beyond just evidence to help people understand these things? Because like we know that COVID vaccines work, like that piece was like, even though that was a huge effort to get vaccines that work, like the uptake limiting variable now is not that, it's other misinformation or ability to take these competing messages and figure out what's accurate and what promotes health. And so, but this is a space that medical organizations and academic groups haven't often done. They've just said, well, we produce the evidence, now it's your job to do that. But whose job is it to do that if it's not happening?
Eric, of all the work you've done, the impact you've made on me personally around the understanding that this story has already been told once before, and we can lather, rinse, and repeat what we did with the emergency medical. And I tell you, the very first few times you were talking about the baseline of emergency medical, it was just really hard to get my head around that it wasn't always like we have it now, an easy to access number, a quick ambulance response, a hospital emergency department that just lets me in the door. So our next interactive segment will revisit that, and it is the emergency medical system trivia. John Draper, I'm going to push the first one to you because I know Eric knows the answer to this. What was the first emergency medical service to provide advanced pre-hospital care by trained paramedics?
Oh my gosh.
The first emergency medical service to provide advanced pre-hospital care by trained paramedics. Eric, does the wording does it trip you up, or do you know the answer to this one?
I think the answer you're looking for is the Freedom House Ambulance Service.
The Freedom House Ambulance Service. That's exactly what I was looking for.
Eric?
That was in the Hill District. Started out in the Hill District of Pittsburgh, Pennsylvania.
Yeah. Let's see.
Really powerful. Next one. Eric, you referenced the 988 Behavioral Health Crisis Coordinating Office. Who helps standardize emergency medical services training and protocols across the U.S.?
Who, as in a person, or like a...
I'm not going to say more because
emergency medical protocols, not 911.
It isn't. The who is not a person.
Yeah, it's an association.
I'm having this issue where when you know too much about something and you're not sure what the right answer on the test is.
Yeah.
And details matter with Eric. You can't John, you can't just sneak by the Chula Vista police person and say it's San Diego County. So the answer I'm looking for here is the National Highway Traffic Safety Administration. Eric, what was tripping you up in the way I asked it?
Well, because there were a number of stages in which this happened.
Yeah.
And so so that was confusing. But that makes a lot of sense, and it's one of the things we talked about in the
Interesting.
Freedom House article in the New England Journal of Medicine, which, by the way, is the first major medical journal to have an article on 988. That featured 988 was that article. But one of the main causes of a rising and new cause of civilian deaths was motor vehicle accidents on these new developing interstate highways. And there was no mechanism to get those folks to emergency care.
Right.
And the statistic came out that became really politically kind of like powerful was that you were more likely, a soldier during World War II was more likely to die after that vehicle accident versus if he was injured on the battlefield.
Yeah.
And because they had a system of medics to be able to respond to that we didn't have here.
Yeah, amazing. The report that came out in 1966, the landmark report that spurred the development of our modern EMS system, has become such, I carry it under my arm like a Bible, and yet I still can't remember the name of it off the top of my head. Do either one of you know the name of the report, Eric?
I have it here in front of me, so it's a bit cheating. But accidental death and disability, the neglected disease of modern society.
Absolutely. Where and when was the 911 emergency number first introduced?
Where or when?
Both.
Alabama, 1968.
Yeah, but what was the city?
Birmingham?
Eric?
It sounds right.
Haleyville, Alabama. Haleyville.
Where was it called too?
What's that, Eric?
Where was it called too?
That's a good question. Yeah, it might have been.
That part might have been Birmingham.
Yeah.
What has Dr. Rebecca Neustaedter argued was the original intent and rationale for the deployment of 911? John, do you know this one?
I do. Basically, to manage the civil disobedience.
To manage a police response to civil disobedience. It was in that Law and Order era, and the civil rights movement.
Get them protesters off the street.
Yeah. Eric, what year was the Emergency Medical Services Act passed to provide federal funding for regional EMS systems?
Yeah, federal funding, guidance, and support, 1973.
Look at you. I tell you, Eric, if you get this last one, you're going to come out of this is our 16th podcast, John Draper, and he'll get the gold star of gold stars. This is bonus points, Eric. Come on. But now we're going popular culture. What was the name of the 1970s show which popularized the paramedic profession and raised awareness of both 911 and the EMS systems?
I'm going to lean on John Draper, who might have been around then.
You're damn right I was. And yes, I was watching television, but I guess a different channel.
John Draper, no more young people on the show. We're only going to do old white guys from now on after Eric. Now, what was the name, John Draper?
I don't know. What was it?
It was called Emergency.
I never watched that.
I guess it's a precursor to 911 Austin or whatever the shows are today. So, Eric, wow, the work you're doing and will continue to do over your career. Thank you so much for being with us. And it brings us to, John, the incredibly true tales of Behavioral Health Link.
We'll see how true, Dave.
So, John, this actually predates Behavioral Health Link, but Mark Livingston, who was one of the executive leaders with Behavioral Health Link, and myself and our team for many, many years, he and I were co-facilitating a process work group, counseling group of adolescents. This would have been 96, maybe, John.
Yeah.
And in that group, one of the young people was just talking about his weekend, and he had gone to the hospital over the weekend because he hurt his ankle. And just mentioning the word hospital triggered the young African-American. We'll call him Ken. Ken said, speaking of hospitals, I'm still traumatized by my visit to the hospital. And months earlier, I had been very concerned about his safety. I didn't know what else to do but to get him some involuntary care. I worked through our psychiatrist, the police came out. He was a wonderful young man, but he was tall, he was black, and I never anticipated that law enforcement would bind him hands and feet with me sitting there saying, this isn't necessary. What are you doing? Unfortunately, the experience he had in inpatient was probably, according to him, much more traumatic than the engagement with the police. So it was an ongoing issue for him. It was becoming a barrier. And clinically, I thought I had a relationship with him where I could challenge this a bit. What he said at the time was, Dr. Estroff, he was the psychiatrist, he did that to me. And I thought it was going to be a good idea for me to say, Dr. Estroff didn't do that to you. I did. And what I was going to say was why I was worried about him and go into but I never got past I did. And I hadn't even finished the statement before I could see the look in his eye. This was a terrible idea. He stood up. He actually raised the chair above his head. And huge crocodile tears coming down his cheek. The rest of the group exited. And Mark, I remember it like it was yesterday, there was a door between the group room and the outside and had a little round portal in it. And Mark is looking at me like this. Do I need to call the police? Because Ken was a lot taller than me and he had that chair above his head. And I just stood beside him. And I said, that's how we got here. So I was able to give him some space to talk about this traumatic experience he had been through. And the irony of this, ultimately we brought the group back in. He worked through, my cool idea of how he would clinically work through this. Ultimately, he did work through this experience, but I asked the group to process what Ken had done well. And one of the guys says, he put down the chair. That's what he did well. So it was quite this interaction, John, of us not knowing the unintended consequences of all of the way we do all of this and the impacts that it has or can have.
And the disarming impact of your dealing with it very differently.
Yeah.
And all of that sounds like it might have happened and probably did happen, except for the beard that you have in that picture.
There's a beard in the picture? Where's that?
Beard.
The
beard. I don't think you've ever had a beard, David.
John, I would have a wonderful beard. I did a mustache once with my light hair. It was hard to see that I had the mustache. So
yeah. Okay.
But John, this sets the stage for some plain truth today.
Let's hear it, David.
So this issue of care that actually feels like care to the individual, Dr. Don Berwick and the team at the Institute for Healthcare Improvement, they were the ones responsible for the quality initiative and triple aim of healthcare: improve the patient experience, improve the health of the population, and reduce the cost while you're doing it. They really ran into, they were surprised at the fight that came out around putting the needs of the person first. Now, again, they weren't talking about psychiatric services or behavioral health care or crisis care. They were talking about just the healthcare system as a whole. And the industry did not like, and they fought over concepts like the needs of the person come first, nothing about me without me. Every person in need is the only person in need. But let's hit the bullseye. Ultimately, Dr. Berwick put forth the definition, which I'm going to bring into the crisis space. The person in crisis tells us, I was given exactly the help I needed and wanted, exactly when I needed and wanted it. That was a bridge too far for the healthcare collaborative that was putting this work together with healthcare leaders. and they watered it down with something along the lines of patient-centeredness. And ultimately, Dr. Berwick wrote a editorial for Health Affairs, and he challenged. The name of that article, Eric, was "What Patient-Centered Should Mean: Confessions of an Extremist," way back in 2009, before Eric is changing the world, John. But what he really concluded was that this idea that the person tells us I was given exactly the help I wanted and needed, exactly when I wanted and needed it, that's seldom what we deliver. We resist the idea of patient control. We simply aren't willing to give that up. Now, I think this idea of lived experience really, John, is a key to this whole discussion. Dr. Berwick was a psychiatrist, or was actually I think he was an internist, but he was a medical doctor, a policymaker, and a researcher. But it was when he became a patient himself and had a family member who was a patient, it was the experience of being a patient that really is what changes us and helps us to see the actual impact of the controls we won't give up as administrators. So I want to end this plain truth with what he wrote at the conclusion of that editorial. He wrote, "I freely admit to extremism in my opinion of what patient-centered care ought to mean. I find the extremism in a specific location, my own heart," he wrote. "I fear to become a patient. What chills my bones is indignity. It is the loss of influence on what happens to me. It is the image of myself in a hospital gown, homogenized, anonymous, powerless, no longer myself. It is the voice of the doctor saying, 'We think,' instead of 'I think,' and thereby placing that small verbal wedge between himself as a person and myself as a person. It is the clerk who tells my wife to leave my room or me to leave hers without asking if we want to be apart. Last month, a close friend called a clinic for her mammogram report and was told, 'You have to come here. We don't give that information out on the telephone,' she said, or they said. She said or replied, 'It's okay, you can tell me.' They said, 'No, we can't do that.' Of course, they can do that. They chose not to. And their choice trumped hers, period. That's what scares me," Dr. Berwick wrote. "To be made helpless before my time. To be made ignorant when I want to know. To be made to sit when I wish to stand. To be alone when I need to hold my wife's hand. To eat what I do not wish to eat. To be named what I do not wish to be named. To be told when I wish to be asked. To be awoken when I wish to sleep. Call it patient-centeredness, but I suggest," Dr. Berwick wrote, "this is the core. It is that property of care that welcomes me to assert my humanity and my individuality. If we be healers," he concluded, "then I suggest that that is not a route to the point. It is the point." John, I'll argue the plain truth is that's the point of the promise of 988 as well.
Amen, David. That is a very profound, plain truth. That notion of, I am the expert in medical care, but I'm not the expert in you. You are the expert in you. So the only way I can be an expert in your medical care is by collaborating with you and joining you as a partner, inviting you to be, and really letting you lead. I'm just the passenger, but you're the driver. And that I think is really lays at the heart of what Don Berg was saying and what we're trying to accomplish with 988, just as you said. Well, David, I really want to thank Dr. Eric Rafla-Yuan for joining us today to share just a fraction of the outstanding work that you've been doing in California, Eric, and nationally to improve access and reduce discrimination in crisis care. So thank you for joining. And next week, we have Columbus, Ohio's Jonathan Thomas here to talk about their state-of-the-art and industry crisis receiving facility and the magic that makes these miracles happen. But as for now, that's it for today. So stay cool, stay anchored, and look out for the lifelines that we toss your all's way next week.
Eric.